Good evening, Goswami sir. Nitya speaking. Good evening, Inder sir.
Good evening. Good evening.
Good evening, Ajay ma'am.
Hello, Inder.
Hello, ma'am.
How are you?
Fine, ma'am. How are you?
I'm fine.
Good evening, ma'am.
Good evening. मैं हेडफोन यूज करूँ इसको थोड़ा खुद हो जाएगा.
Yes, ma'am.
Will you just see हेडफोन से आवाज बराबर आ रही है कि नहीं?
आपका आवाज
थैंक यू. एक बार हेडफोन पे ट्राई कर लेते हैं. हेडफोन नहीं ट्राई किया था. हेलो.
Hello.
अभी वॉइस क्लियर है इंदर?
हाँ, clear, ma'am. Clear.
कभी
clear.
इको हो जाता है तो फिर मुश्किल
हाँ
है.
प्रतीक सर.
काफी अटेंडेंस है. गुड.
Hi, Inder, can you hear me?
Good evening, sir.
Inder, can you hear me?
Yes, sir. Yes, sir. You are audible, sir. Good evening, sir.
Okay. Hi, Inder. Hi, Dr. Razia.
Hello, sir. How are you?
Hi, yeah, I'm good. I'm good. I'm good. Good to see you all.
Same here.
Same here, sir.
Hi, Pratik.
Hi, sir.
अब अपनी शक्ल भी दिखा दे.
प्रीसियस है सर, ऐसे नहीं दिखेगी.
हाँ,
sir.
Pratik.
Hi, sir.
Hi, Pratik. Good to see you.
Now the audio and video are working perfectly, sir.
Okay, fine, fine. एक्चुअली ये सिस्को वाले में मैंने किया नहीं है, हर बार जूम में किया है ना, तो इसलिए प्रॉब्लम आती
Yes, sir. First time I also faced some problem.
है. ओके. डॉक्टर रजिया, मुझसे वापस क्वेश्चन मत पूछ लेना.
सर आप बैकअप हो आज. टॉपिक इतना वास्ट है, आप मेरा बैकअप. चलो मैं खुश हूँ कि आप हो ना आज मॉडरेटर. ठीक है.
मैं वही तो कह रहा हूँ, बड़ा कंफर्टेबली मॉडरेटर का पोजीशन है. कोई सवाल पूछ ले तो डॉक्टर गोस्वामी.
गुड इवनिंग गोस्वामी सर.
गुड इवनिंग, नमस्कार to everyone.
हाय डॉक्टर
Hi,
गोस्वामी.
sir.
Hi, Goswami,
अरे
sir.
privilege डॉक्टर.
Everybody is happy कि
और क्या
कौशिक सर
चाहिए?
मॉडरेटर है.
बस बस, मतलब मजे ना लिया करो डॉक्टर गोस्वामी. आर वी ओपन?
5 मिनट वेट करते हैं सर.
हाँ, नहीं मतलब हम बात जो कर रहे हैं वो सबको नहीं सुनाई दे रहा ना, ये पूछ
हाँ,
रहा हूँ.
सबको सुनाई दे रहा है सर. वी आर ओपन.
So there is no option to but to stay very decent.
We will make a WhatsApp group na later on, then we can.
Hi, Ajay ji.
Sir, good evening.
There, sir, we can go ahead, I think.
Okay. Good evening, everyone. We welcome you on the day 4 of the Pediatric Neuromuscular Disease Update organized by the Department of Pediatrics, AIMS Rishikesh. As our eminent speakers have already covered congenital myopathy, congenital muscular dystrophy, Duchenne muscular dystrophy, LGMD, spinal muscular atrophy, and other motor neuron disease. Today, we will discuss hereditary neuropathy and myotonia in children. For today's session, our eminent chairperson is Professor Jayasankar Kaushik sir. He sir did DM Pediatric Neurology from All India Institute of Medical Science, Rishikesh. Currently, he is professor in the Department of Pediatrics, PGIMER Rohtak. He is heading Pediatric Neurology Services there, and he is the active member of AOCN. And sir is editor of Neurology section of prestigious Indian Pediatric Journal. Sir is actively involved in organizing various national conferences and various CME all over the India. Sir has around 100 publications in various reputed national and international index journal in his credit, and he sir wrote various chapters in textbook of pediatrics and pediatric neurology. Over to you, sir. You are not audible, sir.
कौशिक सर अनम्यूट कर दीजिए, अनम्यूट योरसेल्फ.
Can you hear me now?
Yes,
Now
sir.
you are audible.
Yeah, thank you, Dr. Inder, for your kind introduction, but I know all of them are lies that is written in the slide. So I'm just a consultant, and I'm in the learning stage, and we have worked together, and it was a great learning at AIMS. And you have today, after a wonderful session of pediatric neuromuscular seminars that have been organized by AIMS Rishikesh by Dr. Inder and Dr. Pratik. They are already doing an excellent job, and congratulations to Dr. Inder and Dr. Pratik. You're already on a great height, and you're doing a very, very good job. And hope you continue to spread the knowledge to all pediatricians, pediatric neurologists, and we all continue to learn together. So, but now what I'm going to tell about the next speaker, Dr. Razia, is all truth. She is an excellent orator, par excellence, and I am a big fan of her talks. And she had done her pediatric DM, pediatric neurology from PGH Chandigarh. She is currently a consultant pediatric neurologist at Ankura Hospital in Hyderabad, and she has received the prestigious Fukuyama Award, and she has various publications in reputed national and international journals and various book chapters. Her field of interest is neuromuscular disorders, neuroimmunology, and epilepsy. I'm a big fan of Dr. Razia. She is an excellent orator, and she keeps things very, very simple. Over to you, Dr. Razia, to cover one of the most important topics, that is hereditary neuropathy. When should we think of hereditary neuropathy, and when should, as a pediatric resident, should thinking of hereditary neuropathy? So over to you, Dr. Razia.
Thank you so much, sir. Thank you for that kind introduction. So today, Inder has asked me to cover a very wide topic. And first of all, I would thank all the organizers to give me this opportunity. We all know that neuropathy is an important exam topic, as well as in clinical scenario. We come across many conditions where sometimes we get confused. We have to evaluate children who come with neuropathy. So hereditary neuropathy is a heterogeneous group, and it covers approximately 20% of various causes of neuropathy. Today, we will see briefly about the clinical characteristics, what are the different types, how to evaluate, and how to manage these children. So let us start with a clinical scenario. So we have a 11 years old girl who is symptomatic for the past 4 years. Parents noticed that she was initially walking on toes, and lately she also had difficulty in getting up from squatting position. They also felt that there was thinning of legs, and following which, for the past 3 years, she complained of slipping of slippers, and lately she also complained of difficulty in buttoning and holding objects. So this was an insidious onset, gradually progressive weakness involving lower limbs, initially followed by involvement of upper limbs, and the weakness was more history-wise more distal as compared to proximal. So on detailed history taking, we did not find any positive sensory symptoms. There was no features of autonomic involvement. She was cognitively preserved, no features of cranial nerve involvement, and the family history was also not contributory. Examination, there were no palpable nerves. She had bilateral pes cavus, no features of fat soluble vitamin deficiency. Her higher mental functions and cranial nerve examinations were also normal. On motor examination, we found that her bulk was symmetrically reduced below knee, as well as there was wasting of small muscles of hands. Tone was normal, and on examination of power, both lower limbs were weak, and weakness was more distally. Across ankles, ankle dorsiflexion was more weak as compared to plantarflexion. Upper limbs, the proximal muscle power was preserved. She had a hand grip. Hand grips were weak bilaterally, and also the intrinsic muscles of hands were weak. Reflexes were diminished in upper limbs, though they were elicitable, and absent on both sides over knee and ankle. However, the plantar reflex was flexor. This is the gait of index child. You see that she has an increased arch bilaterally, and while she walks, she drags her forefoot and she is unable to clear her leg off the ground. So she had bilateral foot drop. Further examination did not reveal any sensory loss. There was no sensory ataxia. Autonomic system examination was normal, and nothing else was remarkable. So here we have a 11-year-old developmentally normal girl. She has gradually progressive symmetrical bilateral lower limb weakness, which is more distal. On examination, she has pes cavus, wasting of small muscles of hand, areflexia, and foot drop with no sensory and autonomic involvement. Okay, so whenever you have a child with peripheral neuropathy, clinically you have to differentiate into 4 major patterns of presentation. So some children will have predominant motor symptoms, some may have predominant sensory symptoms, some can have recurrent neuropathies, and few may have painful neuropathies. So whenever you're talking about inherited neuropathies or inherited neuropathies, remember that inherited neuropathies will never present as a painful neuropathy. So they will not have positive sensory symptoms. They can have pure motor symptoms, they can have predominant sensory symptoms, they can also present as recurrent neuropathy, but they will never present as a painful neuropathy. Now, neuropathy again has various causes. This is the simplest diagram which I can show you. So if you broadly classify, neuropathy can be acquired, it can be inherited, but whenever you come across an insidious onset, gradually progressive, distal, symmetrical involvement, which can be motor or sensory motor, without any positive sensory symptoms, always think about inherited neuropathies. Okay. Now, so these are the hard handles whenever you see a child. Slow progression, foot deformities, lack of positive sensory symptoms, and distal symmetrical involvement. So inherited neuropathies again can be either a part of multisystem disorder with or without CNS involvement, or it can be an isolated peripheral nervous system involvement. So for today's discussion, we will restrict ourselves to peripheral nervous system involvement because the multisystem disorder is again a vast topic. So I'll stick to isolated peripheral nervous system involvement of inherited neuropathies. The common ones are Charcot-Marie tooth disease, hereditary neuropathy with pressure palsy, distal hereditary motor neuropathy, and hereditary sensory and autonomic neuropathies. By and large, Charcot-Marie tooth disease is the largest and the commonest cause of all inherited neuropathies. It is named after 3 physicians who identified this entity in the 18th century. And if you look at all inherited neuromuscular disorders, CMT is the most frequent of all. The prevalence is somewhere between 1 in 1200 to 1 in 2500 kids. So usually they will have foot deformities and claw hand. So foot deformities can be pes cavus, as we saw in the index child. They can also have incurving of the heels, inverted champagne bottle or the bowling pin appearance because of atrophy of tibialis anterior and peroneus muscle, and wasting of small muscles leading to claw hand as well as foot drop as we saw in the video. So what happens is initially when a child comes with clumsiness or frequent falls, we usually tend to miss the pes cavus because initially pes cavus is mild and reducible. There are different stages of pes cavus in CMT. So gradually this pes cavus increases and it becomes irreducible. The arc becomes more prominent. Then they have a hammer toe, which is again initially reducible. Later it becomes irreducible. Gradually they have incurving of heels, and then there is subluxation of metatarsophalangeal joints. So it's important to try and see even when they have milder or the initial features of pes cavus. Now, classification of CMT is a little confusing. You can classify CMT under various categories. You can have a clinical classification, or you can classify them based on the nerve conduction studies, based on mode of inheritance, or which we follow is the genetic, based on genetic mutations. So we have seen the classical phenotype of Charcot-Marie tooth. The second phenotype is profound sensory impairment, and the least common presentation would be selective involvement of upper limbs in the initial aspect of the disease. Electrophysiologically, the nerve conduction velocities of motor nerves is used to classify them further. So if the motor nerve conduction velocity is less than 38 meter per second, then we categorize them as a demyelinating variant. If it is more than 45 meter per second, then we categorize them as the axonal variant of Charcot-Marie tooth disease, and the intermediate velocities are classified as intermediate variant. Remember, the motor nerve conduction velocities of upper limb is taken into consideration. Some people also say that ulnar nerve is preferred. So usually when you do nerve conduction studies in these patients, the findings will be symmetrical, but in small percentage, you may also have asymmetrical findings. So those who are familiar with nerve conduction studies, you know that whenever we are dealing with demyelinating neuropathies, along with reduced conduction velocity, we also find temporal dispersion and conduction block. Whereas in Charcot-Marie tooth disease, you will only find slowing with absence of temporal dispersion and conduction block. So you will not see any conduction block or temporal dispersion. You will only find slowing of motor nerve conduction velocities. So we performed NCS of the index child, and here we see that the velocities are definitely way below 38 meter per second, both in median as well as in ulnar nerve, but there is no conduction block or temporal dispersion. So electrophysiology not only helps us in differentiating between axonal and demyelinating pattern, it also helps us to further classify the axonal inherited neuropathies. So you may have an isolated pure motor axonal neuropathy, you can have pure sensory axonal neuropathy, or you can have mixed motor as well as sensory axonal neuropathies. Sometimes it also helps us to differentiate with conditions which may mimic a peripheral neuropathy like distal myopathies. So the traditional classification was based on the electrophysiological pattern. It was based on the mode of inheritance. But now we no longer use this classification. For example, CMT type 3 was used to indicate the severe phenotype and recessive disorders, which was later replaced by Digerin-Sota's phenotype. And after the identification of lots of genes which are responsible, now we follow the extensive classification. This is a small example where CMT1, the demyelinating variant, has been further classified based on the causative gene, like peripheral myelin protein, the myelin protein 0. Then you have lots of other genes. So actually there are more than 105 genes which have been identified with Charcot-Marie tooth disease. But if you look at the overall, the common genes which are responsible for the CMT presentation is limited to 4 of them. So 90% of patients with CMT will either have a peripheral myelin protein mutation, or they will have a mitofusion or myelin protein 0 or a gap junction protein beta 1 mutation. So GGB mutation is usually associated with X-linked CMT. Rest PMP22, MFN and MPZ can be associated with either demyelinating or axonal variants of CMT. So these are the common ones. Nerve biopsy, nowadays it's not frequently performed, but if you perform nerve biopsy of Charcot-Marie tooth patients, you will see a typical onion bulb pattern. You can see here there are layers of myelin across a nerve. So this is a normal nerve where you will not find multiple layers of myelin, but here around the nerve you can see there are multiple layers, which gives an onion bulb appearance. So this onion bulb appearance occurs because of repeated demyelination and remyelination. So there are layers of myelin which covers the nerve ending. So nerve biopsy can sometimes be helpful if you have to differentiate between CMT and CIDP or from other inflammatory conditions. So usually what happens, the protocol, the evaluation strategy in these patients should be: first, you have to take a detailed history, examine the patient, localize the lesion. Detailed family history is important. Analyze the pedigree. What is the pattern of inheritance, if at all there's a positive family history? Then perform electrophysiology and only then go for genetic analysis. If at all you skip any of these steps, jumping into genetic analysis is not going to help you. In fact, it can be confusing sometimes because, okay, so before another strategy which is used, which has been suggested in few books, is based on the nerve conduction velocity of motor nerves. So if the velocity is very slow, less than 15 meter per second, and a child has developmental delay, then it is suggested to test the single genes of PMP22 or MPZ. If again they are also negative, you can proceed with the rarer variants of uh, gene analysis. But usually, when you analyze this way, you may have to spend more time and I mean, obviously, if you do a step-by-step analysis, the time taken to establish a diagnosis is prolonged. So now with the ease of NGS panel and multi-gene panel, people straight away jump to NGS analysis. So the recent recommendation in 2018 says that you first analyze the common genes, and if it is negative, you can proceed with the NGS panel. But if we do not take a detailed history and if we do not have a probable diagnosis or pattern of inheritance in our mind, then the results of NGS panel may also be confusing many times, because a single gene, for example, here, this GDP gene, a single gene can have varied manifestations. So this gene can have an autosomal recessive mode of inheritance. It can also cause an autosomal dominant kind of illness, and it can present with axonal as well as demyelinating or an intermediate neuropathy, peripheral neuropathy. Moreover, there are many genes which overlap. So the mutations which cause CMT can also there are shared genes which can cause myopathy. It can cause amyotrophic lateral sclerosis, or you can have some genes which are shared with SMA. So it's more important to have a clinical diagnosis first rather than you have a genetic diagnosis. So genetic diagnosis should help you. It should not replace your clinical acumen. When you come to management, sadly, we don't have any specific treatment for this. The majority of care is basically supportive care. We need a multidisciplinary team where physiotherapists and orthopedicians they take care of the patients. We need ankle foot orthosis. Some may also undergo tendon lengthening. They need gait practice so that they don't fall, and gait training is needed. There are multiple trials going on, but till now we do not have any promising results. Second case for today, this is a 6-week-old male child who is born to a third-degree consanguineous couple. Second born, the first sibling is asymptomatic. Parents were concerned about decreased movements of all the four limbs, which was noticed around day 15 of life. By 1 month of life, mother felt that the child had a very weak cry and he was also breathing fast. Apart from this, there was no history of seizures or feeding difficulty. The airway was stable. There was no drooling of saliva. Antenatal period was supervised. There were no history of decreased fetal movements or polyhydramnios. He had smooth perinatal transition. He had a good cry. There was no birth asphyxia. He could feed well up for the initial 2 weeks of life. There was no family history of developmental delay, sibling death, or any other neuromuscular disorders. Examination wise, he was a well thriving child. There was no microcephaly. He had tachycardia, tachypnea. With respiratory failure, he was unable to maintain saturation in room air, which improved with supplemental oxygen. Apart from that, there was no dysmorphism, contractures, limb anomalies, hip dislocation. He also had intercostal muscle weakness, which led to paradoxical breathing. Other system examination was unremarkable. So we are dealing with a child who has significant respiratory weakness as well as paucity of movements of all the four limbs. Motor examination revealed that child was alert. There was no ptosis. Extraocular movements were normal. Gag reflex was weak. He had a weak cry. He had axial as well as appendicular hypotonia. Bulk was preserved, but power, he had significant weakness of all the four limbs. Power was only 1/5, and there was global areflexia. Examination of parents were normal. So with these findings, we thought either the child has an SMA or an SMARD or any other peripheral neuropathy which presents in the infantile period. Evaluation did not reveal any elevation of muscle enzymes. Cardiac assessment was normal. Thyroid functions were normal. When we did nerve conduction velocity, we found that his peroneal nerves were not excitable. We could not record any CMAP or the nerves were inexcitable. And even on the right tibial nerve, we hardly got a very small muscle action CMAP, and the conduction velocity was reduced. It was only 24 meter per second. So this child, and even the sensory nerves were not recordable. The snaps of both upper limb and lower limb were absent. So this child had both motor and sensory involvement. Probably the involvement was very severe. That's why the nerves were not excitable on the lower limbs. So we proceeded with the genetic evaluation where this child had a homozygous mutation of PRX gene, which is known to cause myelopathy, and it is associated with Dejeron-Sottas disease. So there are many inherited neuropathies which may present in the infantile period, and there are two broad clinical phenotypes of inherited neuropathies of infantile onset. One phenotype would be the congenital onset where child has hypotonia, breathing difficulty and feeding difficulty like the index patient. And the second phenotype would be delay in motor milestones with or without foot deformity. So the common genes here which are mentioned in red are those which have an autosomal dominant inheritance, and those which are mentioned in green, they are inherited in an autosomal recessive pattern. So index child had this PRX mutation, homozygous mutation, which was an autosomal recessive inheritance, and this child presented early in the first half of infancy. Management is largely supportive. Unfortunately, we could not convince the parents to go for carrier testing and antenatal diagnosis in subsequent pregnancies. So third case for today, this case has been shared by Dr. Hansa. This is a 20-month-old boy who is again born to a third-degree consanguineous couple. This child complained of global developmental delay, insensitivity to pain and temperature, which was noticed in early infancy. Apart from this, there were no features of autonomic involvement like hyperthermia, anhidrosis, flushing, or absence of tears. There were no behavioral abnormalities. Examination revealed subtle dysmorphism, and he had features of self-mutilation where he had chewed his lower lip as well as a little bit of anterior part of his tongue. There was mild hypotonia, absent superficial and deep tendon reflexes, and there was generalized absence of response to pain and temperature. So with this, we had possibility of either HSAN, hereditary sensory and autonomic neuropathy, or congenital insensitivity to pain, or atypical presentation of CMT type 2B. The nerve conduction studies revealed absent sensory nerve action potentials, and the motor nerve conductions were normal. Genetic analysis detected a homozygous splice mutation in PRDM12. So this was consistent with HSN type 8. So HSAN was previously categorized only up to 5 types, but now with newer genetic diagnosis, we have further more types of HSAN which have been identified. So HSAN basically is a small fiber neuropathy, and the autonomic component of hereditary, sensory, and autonomic neuropathy is variable. Some patients may have significant autonomic involvement and present with hypotension, syncope, GI symptoms, urinary symptoms, etc. And majority of patients may also have a normal nerve conduction study because of the selective involvement of small fibers. These images have been shared by Dr. Prashant of one of his patients, where you can see due to self-mutilation, there is auto-amputation, the child has multiple injuries and charcot joints. So till now, total 9 variants have been described, and every variant has its own typical clinical features. Type 1 and type 7 are inherited in an autosomal dominant fashion. Some variants can also have hearing loss. In type 3, typically the touch sensation is preserved, and variant type 3 and type 7 may also have hyperhidrosis. Otherwise, the diagnosis is predominantly based on the genetic mutation which is identified. So management is again largely supportive, but we need a team of people to manage these patients. We need to protect the limbs to avoid amputation and osteomyelitis. So the way we advise self-examination for all diabetic patients. Similarly, in these patients also, we have to advise them to perform self-examination of feet for any signs of early trauma, any redness, swelling, and then proper cleaning and protection is needed. We have to apply lipid-based ointments, or give them appropriate shoes and socks to protect lip biting and tongue biting. It is advised to smoothen the sharp edge of the tongue and of the teeth, and sometimes in severe cases dental extraction is also needed. Because of corneal anesthesia, it's important to protect the cornea also. Artificial tears are used. Some people also perform tarsorrhaphy. Cautery of tear ducts is performed because once you do cautery, there is increased tear production, and clear lenses can also be used to provide protection and maintain moisture. Anhidrosis can be fatal in these patients, so it's important to start antipyretics as even when they have minimal rise in temperature. They have to be Parents have to be advised about cool bath and sponging whenever the patient has fever. Most of them, they also have cranial nerve involvement and abnormal swallowing, for which gastrostomy and fundoplication is advised. For excessive salivation, glycopyrrolate and Botox. Botox can be given into salivary glands, otherwise oral glycopyrrolate can also be given. Some patients also have sleep disordered breathing, for which non-invasive ventilation may be needed while they are asleep. So this is the last case for today, and Ramesh Konanki sir has been kind enough to share this rare case scenario. So this 6-month-old boy, parents were concerned about paucity of lower limb movements, which was apparent around 3 months of life. On examination, higher mental functions and cranial nerves were normal. He had hypotonia. There was no wasting, no deformity. Spine examination was normal, but he had areflexia in both lower limbs and normal reflexes in the upper limbs. Nerve conduction study revealed normal nerve conductions in upper limbs, but motor axonal neuropathy involving only lower limbs. So this is basically SMA with lower limb predominant weakness, where the weakness is more distal, and there is significant gradient between upper limb and lower limb. They may or may not have fasciculations. Some variants have cognitive delay, and some, like DYNC mutations, can also have cortical migration abnormalities. They again have two different variations in clinical presentation. Early onset may have contractures, hip dysplasia, and arthrogryposis, and those who have delayed onset may present with waddling gait and hyperlordosis. So yesterday, Dr. Prabjot has discussed about all SMA plus syndromes, and this topic was also discussed yesterday. So I would say that hereditary neuropathies are heterogeneous. It's important to take a detailed history. Don't miss your clinical acumen, and then later take help of genetic mutations. They are individually, they are rare, but collectively they constitute a significant chunk of all neuropathies in children. That's all. Thank you for patient listening.
Thank you, Dr. Razia. It was, as usual, a very, very wonderful talk, and you had very beautifully outlined the 4 important cases, and you have very beautifully brought out that hereditary neuropathies can be involving a small fiber or a large fiber, and you have also very clearly outlined that children with hereditary neuropathy can present either with like motor delay itself, bigger children can present, or they can present with a floppy infant. And you have very beautifully also analyzed and emphasized on importance of clinical features and nerve conduction before jumping to genetic diagnosis. So it is clinical presentation that is very, very important. And I want residents who are attending the current session to remember that hereditary neuropathies does not always have to mean that it is something that is starting at birth. It can just present to you with a late motor manifestations like motor delay, peripheral atrophy, or they can present to you with a floppy kind of an infant. And nerve conductions, as Dr. Razia has very beautifully pointed out, that it can be involving the motor system, it can be involving sensory, it can be axonal, or it can be demyelinating. So it is clinical feature followed by nerve conduction, followed by genetics that will clinch the diagnosis, and not genetics alone that will clinch the diagnosis. So I think Dr. Razia has very beautifully covered this and made it very, very simple and easy to understand. Thank you, Dr. Razia, for an excellent presentation. There are few questions in the question. I think we will settle these questions before we hand over. Is that okay, Dr. Inder?
Sir, yes, sir.
Oh, fine. So there are a few questions. Dr. Razia, do you want to give a clue as to how can we differentiate hereditary and acquired neuropathy on NCV, and how can we differentiate it?
Okay. So NCV basically has some limitations. NCV will give you two broad categories. Either it is an axonal or it is a demyelinating pattern. But if you, join NCV with EMG, you can make some more, finer assessment whether it's an acute onset or a chronic onset. So neuropathy, as I mentioned, there can be multiple causes, metabolic, toxins, infections, and traumatic, not traumatic. So other causes are also there apart from inherited. But in inherited neuropathies, usually if you do EMG, you will find chronic changes because of denervation, and you will either help differentiate as axonal and demyelinating. Whereas if you for acquired neuropathies, for example, if acquired neuropathies examples are post-infectious like AIDP, then after toxins or after infections, and because of drug-induced. Again, drug-induced neuropathies can be divided into axonal or demyelinating. Most of them will be axonal pattern. So just based on NCV, it is difficult to ascertain the etiology. NCV will mainly tell you about the pathology of the neuropathy. You can take some clues and decide whether it is acute onset or chronic onset.
Yes. Thank you, Dr. Razia. There is another question on clues for antenatal diagnosis of congenital neuropathy. Do you want to put few histories that you want to emphasize? Are there some clues for antenatal diagnosis of congenital neuropathy?
So depending upon the severity and the onset of symptoms, this would be common for all the neuromuscular disorders. So antenatally, we can have some clues. If a child has got a significant neuromuscular weakness, then the in vitro movement is reduced, which can lead to contractures, reduced fetal movements. They can have polyhydramnios. The child may have a low birth weight. And if they are associated with other CNS involvement, then they may have microcephaly. Some of them can have cortical migration disorders, but we can get limited information like polyhydramnios, reduced fetal movements, contractures. When they are born, they may have they may have pterygium or arthrogryposis. I think these are some clues. But obviously, a significant family history. If you have a genetic diagnosis of the proband, then you have to advise antenatal diagnosis in the initial weeks of pregnancy.
Yes, thank you, Razia. There is another interesting question that can different types of hereditary neuropathy be differentiated by a nerve biopsy?
Yes, so nerve biopsy will give you some clues. Like one example was the onion bell pattern in CMT, but onion bell pattern is not limited only to CMT. So anything which causes recurrent demyelination and remyelination will have this onion bell pattern. But it's important to see whether the demyelination it's diffuse or it is a segmental demyelination.
Okay.
So segmental demyelination will occur in patients with CIDP. And if the chronic neuropathy is because of any inflammatory disorder, then you will find infiltration with mononuclear cells. Now, another common neuropathy is HNPP, that is hereditary neuropathy with Fischer palsy. I did not discuss that for the sake of time. So, if you take HNPP, in HNPP, the nerve biopsy will show unfolding of myelin. So that again because of PMP22 mutation, so you find unfolding of myelin. In SMA, you will find axonal loss. The distal hereditary motor neuropathy, you will find axonal loss. In HSAN, nerve biopsy, usually because we take sural nerve, it may be normal because it's a small fiber neuropathy. In those conditions, you will have to take a skin biopsy.
Thank you. And we can also emphasize on the fact that with advances of genetics, the role of nerve biopsy is almost dwindling. So neuropathology per se, maybe 10 years down the line will be a history that we used to attend probably. So just two small quick question. Is there a clinical score available to assess the severity of peripheral neuropathy?
I did not come across a clinical
Even
score.
I have not come across.
But there was
Have you come across something related to that?
No, sir. The only thing which I could come across was the staging of Pescavus
Okay,
and
okay,
for neuropathy. As such, there was no scoring.
okay, okay. So probably the only thing which comes to my mind is like any motor disability, GMFCS is used. So other than that, probably MAX can be used for upper limb disability, but I can't think of anything specific to peripheral
Right.
neuropathy. So is there any quick your view on role of gene therapy in treating hereditary neuropathy?
Yeah, so there are many proposals about the different treatment options for Charcot-Marie tooth disease, where it is mentioned that majority of the hereditary neuropathy is caused because of duplication of PMP22 gene. So anything which can reduce the expression of PMP22 can be used as a gene therapy for the larger chunk of CMT patients. But they are again in the early phases of experiment, and there are lots of hypotheses and suggestions. But till now, there is nothing promising in gene therapy.
Thank you, Dr. Razia, for covering the topic very precisely and very succinctly, and great job. Congratulations, Dr. Razia. Now I would invite the next speaker, Dr. Goswami, Dr. J.N. Goswami. Dr. Goswami has done his DM in pediatric neurology from PGI Chandigarh. He is currently working in R&R hospital in New Delhi. He has plenty of publications to his credit, and he has multiple projects in which he is involved. He is a very favorite speaker for many of the conferences. So he's an amazing orator, and I know that all of you will be glued to your screen when Dr. Goswami speaks. So over to you, Dr. Goswami, to speak on one of a very, very interesting topic, that is, can you share your slides, Dr. Goswami? You need to unmute yourself.
Yeah, thank you so much. And can you see slide?
No, Dr.
Cannot make it
Goswami,
as
we are
one.
not able to see it.
You see me?
Share screen one, sir. First share, then share screen one. Yeah, it is coming.
It's coming.
We
Yeah,
can-
am I on?
Fine.
Yes, Dr. Goswami, over to you to cover myotonia in children. Thank you.
Yeah, thank you so much, Dr. Jaya, for words, as we call you, Dr. Kaushik, rather. Thank you for your words, which were too good to be true. And at the very outset, I would like to thank the organizers for this wonderful initiative, Dr. Inder, Dr. Prateek. And it has been a pleasure last 2 days listening to the great speakers. So today I put on this responsibility now to speak about myotonia. Myotonia in children is not a very uncommon condition, but it is not spoken of very commonly. So my presentation roadmap today would be mainly targeted at PG residents. I'd like to give the overview of myotonia in the form of just hold on for a second so that I can select the pointer. Yeah, I would be covering the fundamentals, the current concepts of myotonia. Then I would attempt to give an approach based on the current consensus guidelines and what the future of myotonia is like. So when we talk about myotonia, myotonia refers to a phenomenon of delayed relaxation of muscles and after a contraction. So it is a symptom as well as a sign. The symptom would be that of painless muscle stiffness, generally painless. Sometimes it can be painful. And the signs can change depending on the part of the body involved. In upper limbs, in lower limbs. In upper limbs, there can be difficulty in holding an object and then releasing it. I would show detailed videos subsequently. In lower limbs, it can be associated with difficulty in walking, eyelids, as well as the neck. So before jumping into myotonia, certain basic definitions which PG residents should know are fasciculations, which refer to spontaneous random twitching of a group of muscle fibers, fibrillation, which is twitching of a muscle fiber, which is not seen. Myokemia is repetitive fasciculations. Myotonia I have already told, and neuromyotonia is a continuous muscle activity with muscle rippling. So These snaps show you how myotonia may appear. This is a percussion myotonia. This is a grip myotonia after a grip has been released. Myotonia seen on the tongue and the eyelids, which have been closed and opened, and the individual is not able to open. So myotonia, as such, refers to a heterogeneous group of diseases which have various genetic causes, and they are characterized by clinical myotonia and or electrical myotonia. So what is clinical myotonia? Clinical myotonia, as I have already told, refers to painless muscle stiffness, and the location varies. The location may depend on the particular disease and the exertion and the aggravator. Commonly, eyelids, mouth, hands, and proximal part of the legs in certain and distal in certain. I would come to details subsequently. The triggers may be cold, stress, exercise, and in adolescence, menstruation. There is something known as a warm-up phenomenon. A warm-up phenomenon is a phenomenon whereby initially the individual has difficulty in clenching and unclenching. After doing that repetitive exercise a number of times, it becomes easy. The muscles become more fluidy. The individual can open it with ease. There is something known as paradoxical myotonia, which is the opposite of warm-up phenomenon, and it is a hallmark of paramyotonia. So residents can just remember paradoxical, paramyotonia, paradoxical myotonia, wherein if an individual keeps on doing a particular movement, the movement becomes worse. So what happens in the hand, the grip and dexterity in the form of writing, signing, grip. An individual shakes hand, then he or she has difficulty in opening the hand. Gait problems, eyelid opening, chewing. Sometimes it can lead to, in fact, repetitive dislocation of the temporomandibular joint because of masseter involvement. Neck turning. So here, I'd like to show a video of grip myotonia. As you can see, the child is leaving the hand, there is some difficulty in opening, and as you can see, once again I'll show, the fingers assume now she's clenching. Now when she's opening, there is a sort of a difficulty in opening, and they are splayed. Percussion myotonia is elicited by tapping on a particular muscle belly with a knee hammer. For example, the thenar eminence, the wrist extensor. Even percussion myotonia can be elicited on the tongue. So here the individual is hitting the thenar eminence with a hammer, and the lady's thumb goes into a posturing. There can be myotonia of smooth muscles also, which can manifest in the GI as dysphagia, bloating, abdominal pain, and diarrhea, and in the pupils as delayed pupillary response. Now we go to electrical myotonia. So basic about electrical myotonia is that it is a myotonia which is elicited by an EMG. Something known as a motorbike revving or a dive bomber sound is produced, and there is waxing and waning. So here I'd like to just leave the slide because I would show you this video. And meanwhile, so listen to the sound, and this is something which is normally happening. Just because as I'm showing it for the MD residents, this is something, and just can you appreciate the change? So what happened here is that initially we saw that there were certain impulses, which were certain marks coming on the screen. Those were impulses, those who are not familiar with EMG. So when we put in a needle, we look at the amplitude and then the frequency. Then we also listen to the sound of the motor unit action potentials. And these, there is an increase in the amplitude as well as the frequency. And there is a waxing and waning, which is characteristic of electrical myotonia. Very basic idea about pathomechanism of myotonia is that there is a problem either in the chloride or sodium channel in certain cases, wherein the contracted muscle keeps on contracting because of an increased calcium. This image has been shown because this refers to the voltage-gated chloride channel. I'll talk about it in detail. So these numbers which have been given here are genes which refer to the entities which can happen. So entities which can cause myotonia-like problems in case there is a issue with the chloride channel. In myotonia congenita, there is a problem with the chloride channel, due to which there is an increase in the potassium in the T tubules. The sarcolemma gets depolarized and it keeps on remaining depolarized, because of which there is a sustained contraction. On the other hand, if you see the right-sided box, paramyotonia, there is an abnormality in the sodium channel, which is a gain of function. There is an abnormal excessive influx of sodium, which leads to muscle hyperactivity. The causes of myotonia can be huge. The list is endless, as has been shown here. So when we classify myotonia, there are two types of classifications. In one, we look at the myotonia, whether it is clinical and electrical alone, without clinical, and clinical alone. The list of clinical as well as electrical myotonia encompasses the common ones, the myotonic dystrophy type 1, which is referred to as DM1 and DM2, myotonia congenita, the chloride channelopathies, Thompson and Becker. So this Becker is different from the Becker which was talked about yesterday, along with Duchenne muscular dystrophy. This is something else. So don't get confused by the term Becker. And sodium channelopathies, as has been shown on the slide. Only clinical myotonia, which is actually not associated with electrical myotonia, occurs in certain conditions, such as Schwarzschild syndrome. And only electrical myotonia, where there is no clinical myotonia, can occur in these conditions. Drugs, hypothyroidism, polymyositis, the list goes on. Among drugs, there are certain common drugs like propranolol, and then the drugs which have been shown, D-penicillamine is a common causative factor. But more important and more common than that classification is the classification which I am showing now, wherein we divide myotonias into either dystrophic or non-dystrophic myotonias. The dystrophic myotonias are progressive. They're associated with muscle weakness, muscle wasting, and dystrophy is elicitable, is seen in histopathological examination. Here, initially there is myotonia, it progresses, later the individual has weakness. A non-dystrophic is generally the channelopathies which I had shown earlier, where there is very minimal weakness and atrophy. To confuse you further, the non-dystrophic generally can be classified broadly into sodium channelopathies and chloride channelopathies. So here, to take a break, we have a case. A term male neonate who was born with a good weight of 3.1 kgs was found to be very floppy from birth, had poor respiratory effort requiring mechanical ventilation. There was no perinatal asphyxia, but he was managed as perinatal asphyxia initially. In view of prolonged ventilation, evidence of any IVH, any intraventricular hemorrhage, no HI, neuromuscular illness was considered. But the child did not have any dysmorphism. Hypotonia was present. Tendons are great. The child also had bilateral talipus equinus varus and undescended testes. Examination of the parents was normal. However, on repeat history, mother informed that occasionally during winter she had overriding of her fingers. Her CPK was normal. This is about the mother I'm talking. The NCV was within normal limits. The child's NCV was normal because he was just a 3-day-old neonate. And the EMG of the mother. So I would show the EMG of the mother. Just give me. It is as if a motorbike is being raced. And then the mother was subjected to genetic testing, which had shown increased 1000 CTG repeats, 1000 copies of CTG repeats on DMPK gene, confirming the diagnosis of myotonic dystrophy type 1, which is an autosomal dominant disease with a high prevalence, universal prevalence of 1:8,000, 1 in 8,000. These are Western figures. In a normal individual, there can be repeats of up to 34 of CTG, trinucleotides. And if there are more than 1,000 congenital form, the investigation which I've spoken about, the genetic testing was of the neonate. So there may be individuals who have only 35 to 50, which is more than the normal, but not exactly falling into the symptomatic variant. So they are known as pre-mutations. These pre-mutations with age or with subsequent pregnancies in offsprings can increase in number, which is known as anticipation. The pathomechanism is that this is an RNA-mediated disease. In DM2, there is an expansion of CCTG repeats. In both of them, there are inclusions in the mRNA, and these inclusions lead to binding of certain proteins. The commonest is MBL, as has been shown. That leads to non-functional chloride channel. Loss of chloride channel is a loss of function problem, which leads to muscle hyperactivity. This slide has been shown. It is a very famous cartoon from Lancet Neurology. Different mechanisms that can be associated with DM1 and DM2. The core clinical features in, I would like to talk a bit more about DM1 before jumping into the other entities, because this is the commonest variant. So the core features are 3. There is a distal muscle weakness in the hand, below the wrist, and in the legs. Myotonia, as has been shown, and early onset bilateral cataract. The multisystemic features are huge, ranging from cataracts to retinal damage to corneal damage because of inability to close the eyelids, respiratory system, frequent aspirations, sleep apneas, breathing difficulties, endocrine, cognitive functions may be impaired. Cardiovascular system is involved with, which is commonly seen more in myotonic dystrophy type 2, where there can be arrhythmias and cardiomyopathies, lot of GI issues, and these vary from individual to individual. Sometimes it increases with age. So DM1 is common in pediatric practice. DM2 is not that commonly seen because it is seen from early to late adulthood. Pattern of involvement in DM2 is different. It involves the proximal, the thighs and the arms, upper arms. Myotonia is present in both, though it is much more prominent in DM1. In DM2, it may not be that prominent, though there is pain associated in DM2. And genetically, the DM2, as I had been told earlier, is associated with CCTG repeats, and there is no correlation between disease severity and repeat length in DM2. However, in DM1, it is the contrary. So when do you suspect? This list has been, again, taken from a consensus document, which gives a huge list of conditions starting from autism to ADHD, developmental delay, prolonged recovery of anesthesia, along with a family DM1. So when you have symptoms prior to 18 years, childhood DM. So there is a controversy in the age. The consensus says 18 years, childhood form. Some people still label till 10 years, and 10 to 18 is juvenile. Now about congenital myotonic dystrophy. So it's a variant of DM1 where antenatally the classical features are reduced fetal movement and more polyhydramnios. Preterm delivery may be there. The neonate is born limp, and the neonate also has difficulty in initiating sucking and breathing, requiring prolonged mechanical ventilation. Baby is floppy, generally has contractures, as has been shown in this representative diagram taken from the internet. The face, the inverted Cupid's bow with a high arched palate. The interesting fact is that there may not be any correlation. In fact, there is no correlation in maternal disease severity, as had been shown in our case, which was shown a few slides back, that a mother may be totally asymptomatic, but genetic confirmation is required to diagnose the disease. EMG, as I have already told, is associated with a revving engine sort of a sound. And neuromyotonia is a condition which I'll complete in the same breath, is associated with peripheral nerve involvement. There, the myotonic features are due to a dieback, a Wallerian degeneration of the nerves. And there is spontaneous firing of MUAPs instead of the muscle fiber action potentials. In myotonia, these are the muscle fiber action potentials. In neuromyotonia, it's different. And certain electrophysiological procedures which historically were quite rigorously followed. Now, maybe with genetics, they have come down. One is muscle cooling, where the hands are kept wrapped in a plastic bag and the hand is dipped in a bucket of ice cold water for 20 minutes, bringing down the temperature to 20 degrees centigrade. Exercise tests, short and prolonged, and repetitive nerve stimulation, which is still done. So there are certain electrophysiological differences between DM1 and DM2, which are given in standard textbooks. And the muscle histopathology has been shown just as an academic interest, because now, as was told in yesterday's class also, somehow we are going more towards genetics. And unless there is an issue with either affordability or availability, so normal muscle, childhood onset myotonic dystrophy, where we have these large rings, if you can appreciate. They are known as ring fibers with central nuclei. Here in congenital onset, you see that the muscle fibers appear very small with nuclei which are central. They can be associated, they can be misdiagnosed as central core disease also. The multidisciplinary management in myotonic dystrophy involves a whole list. I'm showing this very busy slide just to impress upon the fact that it's not only neurology. You have to look after the swallowing, the endocrine issues, cognitive issues, so on and so forth. And the list goes on. So to summarize in a nutshell, the type 1 myotonic dystrophy can be thought of when you have foot deformity, myotonia in the hands, and the other multisystemic involvements. Then you take a detailed family history and a neurological examination. If the family history is very against myotonic dystrophy and examination is normal, then if there is no strong clinical suspicion, you can think of alternate diagnosis, but otherwise you go ahead towards genetics. So you see that all of this converts to genetics. If genetics is positive, then you go towards symptomatic and preventative care. If it is negative, then you can take help of a geneticist for variant mutations in DM1 and then consider. And the genetic test that has to be done is duplication analysis for CTG repeats. And in case of a congenital myotonic dystrophy, when you have a baby who's having respiratory failure, floppiness, who has poor feeding, then after that, the flowchart goes the same way as has been shown in the earlier. These flowcharts have been again taken from a consensus document. And screening, the criteria are there, where you do annual pulmonary screening, cardiac screening, something akin to DMD. So with this, I go to the non-dystrophic myotonias. Non-dystrophic myotonias, as I have been told earlier, comprise of two broad categories, the sodium and the chloride channelopathies, which then diverge into the other ones, as has been shown. So the basic difference between the sodium and the chloride is that sodium channelopathies come earlier. And the effect of exercise is sodium worsens and chloride channelopathy improves. The dive bomber is seen in chloride channelopathies, and a sound potentials, myotonic potentials with decelerating motorcycle sound is common in sodium channelopathies. Distribution, sodium channelopathies affect the eyelid, legs, and biceps in the chloride channelopathies. These two are other variants of sodium channelopathies, which are less common, the acetazolamide responsive myotonia, where Diamox or acetazolamide improves it. And myotonia fluctuans, which is a very transient and fluctuating myotonia, which is a channelopathy which is seen more in the second decade, and where in both of these, avoiding potassium is helpful. The chloride channel myotonias, I'm showing the list to confuse you further, have these two entities, the Thompson, which is dominant, and Becker, which is autosomal recessive. And we would be more likely to see Thompson because Thompson affects from infancy to early childhood, and the rest are more or less similar in both. So when you go to sodium channelopathy, so these were the chloride channelopathies. Sodium channelopathies may be classified with those who are having periodic paralysis and those without periodic paralysis. So acetazolamide and myotonia, which I had shown, are without periodic paralysis, and paramyotonia and paramyotonia congenita with hyperkalemic periodic palsy, these are with periodic palsy. So I think I'm skipping these. So diagnostic criteria are given where you have criteria for presence of history and examination, and EMG criteria and genetics. Depending on that, you divide them into definite, probable, and possible. And my source here is Muscle Nerve 2020. And similarly, we have got guidelines for further testing in case of EMG findings which are negative. Then you think of alternate diagnosis. In case EMG is suggestive for electrical myotonia, you go towards genetic testing, and then you go further ahead for specialized procedures. So I'm again skipping these slides because of time issue. So here we have a 6-year-old boy who had history of limping in cold months, occasionally double vision, which was attributed to refractive error. And general and systemic examination were normal. Repeated visits to hospital were not eliciting anything. Went to a rheumatologist who did ESR, ANA, everything was normal. These photographs are representative images, not of the child. So some astute clinician picked up that the child had difficulty in opening the eyes after closing. NCV was normal, EMG was normal, and attempt at cold stress, which I should say that was not very, it was quite on my part, and the child was not cooperative. It was inconclusive. Finally, clinical exome sequencing revealed a mutation in the case has been shown. Just to this on fact, it may be very difficult and not so easy to pick up. Here, even EMG was inconclusive because cold stress was difficult. So how do you approach to myotonia? I go to the final half of my presentation. So there you take a history of suggestive of myotonia. Examination, besides the general examination, you need to do special eyelid, eye closing and opening. And you look at certain special phenomena like warmer phenomena in case of sodium channelopathies, cold sensitivity in case of paramyotonia, episodic weakness, pain, and itself may be the first presentation. Multisystemic involvement, think of myotonia dystrophy. And in case there is a stiffness or cramp, patient gives a history of myotonia. You take detailed history about the same, starting from onset, distribution, whether it is episodic, so on and so forth. For example, we have a girl who was 11-year-old who had difficulty in writing associated slurring. But she said that, again, like the child earlier, that when cold, these problems used to increase. So here, paramyotonia is the answer. Pharmacotherapy for paramyotonia is mainly supportive. Though Cochrane 2000, there has been no meta-analysis 2010. So that says that the drugs are not really that effective, but maxillitin and carbamazepine are used commonly in childhood. So mexiletine again stabilizes the membrane. Carbamazepine also and mexiletine can be used to decrease myotonia. Mexiletine specifically in case the myotonia is very severe, but this drug acts on the channels, so cardiomyopathy and any arrhythmias which are underlying should be screened for. And current ongoing research realms, which I saw in clinicaltrial.gov, and current research is mostly on adults who are ambulating, and they are related to either strength, myotonia, time tests, functional quality of life scores, and certain tissue biomarkers. Future directions are antisense oligonucleotides, which are basically two types. One, these may either block the sequestered, these are the inclusions which are tying up on the RNA. They have been displaced and the muscle can relax in the normal fashion. The other way is RNAs, its active antisense oligonucleotides, where it degrades these. Here it displaces, here it degrades the inclusions, and there is a release of the muscle bind-like proteins. There are certain downstream modulators like pentamidine, actinomycin D, relozin has been studied. So the list is endless, but the list is going the genetic way. So before I conclude, I go to this case where this case has been shared by Dr. Anant Narayan. It's a 6-year-old boy who had motor delay from infancy and a lot of facial twitching for the 6 months prior to visit and had body stiffness for 4 months. On examination, the child had wasting, anemia. He was microcephalic with prominent eyebrows and a flattened face. Some suggestion of muscle disorder by high arched palate, facial myokymia, and bilateral knee contractions. This would give a visual impression. The photograph has been taken after obtaining informed consent from the parents. So selective muscle hypertrophy is there. The build looks solid like a mini Hercules. He had good anti-gravity movements and no cranial nerve deficits. Clinical possibility of Schwartz-Zampel syndrome was kept because of these features. And this, mind you, diagnosis was reached after a lot of research, literature search, because it's a rare entity. There is a increased metaphyseal widening of the tibia, but the image has been, I think, mixed up. The NCV was normal. EMG showed a high frequency decrementing repetitive discharge with pinging sound. Unfortunately, I don't have the video. So there was a sudden burst of activity followed by drop, which is classical for neuromyotonia. Clinical phenotype divides it into two types, type 1 and type 2. Type 2 is the severe neonatal form. And my neuromyotonia can also be because of a lot of acquired causes. So the EMG basket is full in Schwartz-Zampel, which can range from myokymia to neuromyotonia. And the diagnosis was finally in the aforementioned case by genetics, by clinical exome sequencing. Those interested residents who would like to know more about myotonias should definitely go through guidelines on clinical presentation published in Muscle and Nerve and the consensus-based care recommendations, which has been published in Neurology Clinical. With this, I end my presentation. Thank you.
Thank you, Dr. Goswami. As usual, it was an excellent presentation, and you had very beautifully covered all the clinical spectrum of myotonia that can happen, right from starting from congenital myotonic dystrophy, congenital myotonia. So you have very beautifully covered, and the first slide is what I really loved, where you could differentiate between, fasciculation, fibrillation, myotonia, paramyotonia. So I really like the presentation, and I hope all the audience also like the presentation. There are few questions that have been raised by the audience to Dr. Goswami. That can we differentiate congenital muscular dystrophy and congenital myotonic dystrophy in a neonate who presents with a stormy perinatal course?
It will be very difficult because only thing is that myotonic dystrophy would be common, but then ultimately at that age EMG may not be, in fact even standard textbooks say that EMG may not be eliciting much, so we need to go ahead with genetic testing. Just by the clinical a neonate who's floppy, a neonate who's difficulty in breathing on the ventilator, it would be difficult.
Correct. So in addition, probably you can look at the mother and you can examine and do EMG of the mother. That might probably give a lot of clue. And in a child,
Exactly.
So another thing is CPK levels can also give a little bit of clue regarding congenital muscular dystrophy versus congenital myotonic dystrophy. But yes, as Dr. Goswami said, that ultimately we need to rely our diagnosis on genetics rather than trying to put our finger plus and minus towards the other things.
Yeah, Dr. Kaushik, one good anecdote which I had come across in a clinical neurology textbook, Western textbook, is that do not forget to shake hands with the mother.
Correct,
However, it is something against the Indian this thing. So I didn't. So that is basically because the mother has to be seen for myotonia.
Correct. So this is a very similarly. I could remember one of the child whom we diagnosed. The grandmother used to come and say that कि ये बहू बिल्कुल काम नहीं करती है, बहुत lazy है. So history and examining the mother in a floppy child is something so important. And Dr. Goswami has very rightly pointed out. So you can definitely get a lot of clue towards congenital myotonic dystrophy by examining the mother, and it is EMG, as Dr. Goswami said, it is EMG of the mother that will help and not the baby that will be of some help. There is another question, Dr. Goswami, that what is the sensitivity and specificity of myotonia for diagnosing various disorders?
This is actually a googly, a bouncer. But myotonia can be there in some, as I have told, myotonia can be there in myotonic. So when you think of horses, when you listen to sounds of hooves, you think of horses. So if you see a child who is walking into the OPD and he gives history, he looks like there is no difficulty in handling anything. He has myotonia. You think of a myotonic neuromuscular disease. However, if you have a child who's having multisystemic involvement, you are more towards DM1. But there can be conditions where there can be myotonia-like manifestations, like, for example, statin overdose. In a child, we don't give statin that much, mainly propranolol dosing. That also can cause myotonia. But frankly speaking, sensitivity and specificity, I really sensitivity increases definitely if you have got other features. A child who is having myotonia, who has a cataract, who also has hypotonia, the triad is met, sensitivity is pretty high. But if you ask me how much sensitivity is, I won't be able to tell.
Yeah, correctly, precisely. So there is another last interesting question. Is there a clinical test to differentiate between myotonia and paramyotonia?
Definitely. The warm-up phenomena where you ask the individual to clench the fist, clench, open. So after some time, the opening would be more fluid. However, in case of paramyotonia, which I told a mnemonic para for paradoxical, where after doing a number of times, it becomes more difficult. So warm-up as well as the opposite of warm-up.
Yeah. Thank you, Dr. Goswami, for bringing out and simplifying the topic very well on myotonia. And I, as a resident, also used to face a lot of problem understanding when to think of congenital myotonia and when to think of congenital myotonic dystrophy. So I think you brought out this really very, very well. So over to to the organizers, Dr. Inder and Dr. Pratik. And I would thank Dr. Inder and Dr. Pratik for the opportunity to interact in this forum, and I congratulate both of them for doing an excellent job at their place, and I wish them that they continue to spread the knowledge like this.
Thank you, Kaushik sir, and thank you, Dr. Goswami sir and Dr. Razia ma'am. And today both the speakers have nicely presented all the important points about but these are two complicated topics. Still, we wanted to keep this because somehow we come across these cases these days. And tomorrow we are going to cover again important topics, some of the acquired neuropathies, which are more important, GBS and CIDP. And tomorrow we request all of the attendees and participants to join the same time from 7 p.m. to 8 p.m. Again, I want to thank Professor Kaushik sir, Goswami sir, and Rajya ma'am for sparing their valuable time to make this session a successful one. And with this, I am closing the today's session. Thank you, everybody.